Hey, welcome everybody again to our this evening episode or day episode, or whatever time it is on your side. I actually don't really know that. Happy to welcome Theresa to our episode today. Welcome, Theresa.
Thank you. Happy to be here.
We're happy to have you here. So it's fantastic. So for anyone who has been first time visitor to our regular episodes, just a short explanation how it works. You might have a Q&A section in your navigation bar. Just look at the navigation bar. There's a place where I can actually ask the questions during the presentation. So just leave a note. There's no silly question. Just be encouraged to ask any kind of questions you have. And as always, we will also start with a kind of little poll in the beginning. So just to get to know you a little bit better. Theresa, I'm really happy to have you here. And you're actually a researcher, right? What kind of research are you doing?
Yes. I'm actually coming from management consulting, management consulting and entrepreneurship, but now working as a researcher at ETH Zurich, the university in lovely Switzerland. And I'm part of the management technology and economics department within this university. And even more specifically, I'm part of the CDHI lab, which is the Center for Digital Health Interventions. So my research really focuses on anything around healthcare at the intersection of the healthcare aspects and technology, and also to some extent managerial topics. So it's always a very diverse mix of topics that we do in our research.
Yeah, interesting. So management consulting, was it too boring? So what you said, I have to switch to academia?
No, it's never boring. There's always a lot of interesting things to do. No, it's just an opportunity when you go to research, then to go a little bit more into depth. And instead of focusing on topics for a shorter period of time, you have the opportunity to go, as I said, into more depth and research really the reasons why certain behaviors happen, or find out new ways how you can, for example, influence certain behaviors. So you have a lot more flexibility on the impact of your work. But nevertheless, management consulting is also interesting.
Okay, so no worries about that. You actually choose healthcare. Why is healthcare so interesting for you?
Well, from the one side, I was always interested in anything really about healthcare, medical topics. I worked with medical decision making in consulting. For example, I did a lot of projects with healthcare insurance companies. So from this side, I was interested in the business aspects of it, but also from a personal side of it, interested in a topic that really is at the heart of everything and for everyone. Because if we don't have our health, then everything else doesn't really matter and becomes secondary only. And so having the ability to not only research that, but also look at ways of improving the health of other people, what we do with our solutions to some extent, or at least aiming to have some sort of impact, is super motivating in my opinion.
Oh yeah, that's cool. I actually, as you might have recognized, closed the poll. Just for you to know, experience level I asked about conversational AI. Indeed, most of the attendees today are novice to the field.
Mm-hmm.
So it's really our job to pick them up and take them into the train, show them what conversational AI is, your job. I'm really looking forward to that. And from the mixture, we have indeed data science, software engineering, project management, academia as well. So it's a good mix. And others, as always, I just wonder what kind of things I missed. If you like, but can you put in the chat basically? If you say, hey, I would like to be mentioned next time in most polls because it's really not a fit for me, just leave a note in the chat what kind of profession you have. It would be interesting for us to learn from that. Thanks again for taking part in the poll. And I still see people joining us. Welcome again to our AI Swiss episode this evening. Theresa Schachner, Dr. Theresa Schachner, by the way, has also joined us. And she's actually presenting the subject today. What will be our subject, by the way?
It will be about conversational agents or chatbots in a more colloquial term, and their usage in the context of chronic diseases. what can we do with them there?
Okay, sounds interesting. Let's take the floor, Theresa. I shut up my mouth now. What do you do? Okay, thank you.
Perfect. Thank you very much. Let me share my screen. So, perfect. Can you all see the slide view, not the presenter's view?
Yes, it's perfect.
Perfect, good. So finally, knowing how Zoom works after 1 year of lockdown. Welcome again, everyone, to my talk today. I already mentioned the topic, but let me repeat the title again here. The title of this talk today is Chatbots in Digital Healthcare on the prevention and management of non-communicable diseases. We now talked a little bit about me already, but I still want to sort of give a very brief intro so that you know who are you listening to. Stefan already said it. I'm a researcher. I'm from the Department of Management, Technology and Economics at ETH, part of the Chair of Technology Marketing and Center for Digital Health Interventions. We also talked about that briefly. I worked as a management consultant. I also have a past in entrepreneurship. Now I'm working as a researcher. Currently, I'm working on a collaboration with MIT. So parts of the project, or one part of the project that I discussed today, is also part of this exchange with MIT Media Lab. And besides being a researcher, I'm an avid and a regular speaker, so both in the academic as well as the more business and industrial related environments.
Theresa, I'm curious because I'm just looking at the kind of where you are located from a research point of view. Yes. With the Department of Management Technology, Technology Marketing, and when it's digital health interventions. That looks strange, right? Are you related somehow to the medical field as well? Or is it really the marketing, business, administrative side?
So it goes hierarchical in a way. So the department is the management, technology, and economics. So there we have different chairs where it's both about management or managerial topics, also about technology and the economical part. So it's all a bit sort of shattered between the different chairs. Within the chair of technology marketing, we also have a very strong focus on conversational agents in the context of, for example, service marketing. And this chair, together with another chair, shares the Center for Digital Health Interventions. And here, very specifically, we apply what we know from the technology marketing background to aspects of digital health. So we do very specifically focus on digital healthcare and specifically even on interventions, as the name says.
I see. Thank you. Thank you for the explanation.
Yes, perfect. But let me now continue and give you a brief overview of what you're going to hear today. So first, since it's in the name, I want to somehow motivate why we even care about non-communicable diseases or chronic diseases, or NCDs in a shorter form. It's a topic that is at the heart of our center. And even though for us, obviously, it's very clear why we do that, I think it's always worth taking one step back and informing people why it is a topic that we should all care about and why it is so important to spend years and years of research looking into that and trying to work with it. In a second step, obviously, I want to talk a bit about conversational agents or chatbots. CA is the abbreviation for it, very specifically in the context of digital healthcare, because again, this is what we research, where we do research and what we focus on. Since this might come across as a bit dry, maybe, and since sometimes it's a bit high level, and you wonder what you actually do then in research and where's the application and the impact of it. As I said in the beginning, I'm very much interested in having impact and sort of doing research that matters, especially in such an important field like healthcare. I brought two examples today, one for conversational agents where it's about the management of NCDs, or chronic diseases, and one where it's about prevention. And I will go into more depth, but these are two different fields that are super important. But let me start now. So NCDs, for us, as I said, it's very clear this is a topic that we really have to focus about. It's something where it's worth taking time and going into more depth and spending years and years of research on it. But as a layman, you might hear a lot about code, for example. These days, you hear a lot about accidents when you open the newspapers, for example. You might sometimes hear about NCDs, non-communicable diseases or chronic diseases, but very often it's hard to pinpoint unless you are directly involved or suffer from one or have a close one that suffers from one. It's a bit hard, not really tangible to say why it is such a big topic. And in my opinion, or in my view, very often people don't even know how prevalent the problem of NCDs are. So they might think, okay, I know 1 or 2 people suffering from cancer, for example, but you know, lots of people are healthy. But let's look at the numbers.
Theresa, this is also kind of interesting that we talk about basically on conversational AI today, but the focus is on non-communicable diseases. So I'm really looking forward to what you're saying.
Well, it's a funny coincidence, right?
Yes.
But we can also use chronic diseases that makes the mix in one's head a bit less obvious, maybe. No, but we can use conversational AI and conversational agents in a variety of backgrounds. We could also use them for communicable diseases, but now we focus on non-communicable diseases or chronic diseases. And as I said before, it is a really important topic, important in the sense of it affects a lot of people. And actually, that was numbers from 2016, so they might even be higher nowadays. But we know that more than 50% of the world's population have to live with an NCD. So this is a lot of people. And when we think about it, it makes it a lot more tangible. Thinking about that basically every other person might suffer, even today, from a chronic disease. And so now, very quickly, in my opinion, when you look at this number and when you think, oh, wow, that's every second person, it makes it a lot more urgent to think about what do we do if we have one, but also how do we prevent getting one? Because that's obviously the best part. When we talk about chronic diseases or non-communicable diseases, this really covers everything that we can't get from each other, but it is caused by different reasons, such as lifestyle. And this is cancer, cardiovascular diseases, diabetes, respiratory diseases like COPD. These are all the diseases that we think about when we say non-communicable or chronic diseases. Within our center, we have certain foci on which diseases we focus more. So we have different projects that only tackle respiratory diseases such as asthma or COPD or smoker's lung. I will present one later, which is about asthma. We also have a part of projects focusing on diabetes. And we also have other projects that focus on mental diseases, but this is a bit out of focus for this. Still, if we say 50% of the world's population live with an NCD, it doesn't necessarily mean that they all die from it, right? We could say, okay, we might get an NCD or we might get a chronic disease, but you know, that's just how it is. We learn how to live with it. However, when we then look at it, again, the numbers from 2016, we see that 40 million out of the 60 million of deaths in that year were actually caused by NCDs. Again, it's a huge number, and it makes it, again, even more tangible that we say, okay, it might be important to prevent getting one. And it's also very relevant to learn how to manage one, because if we don't manage it correctly, we might die from it. This is obviously not something that we want. When we talk about chronic diseases, very often people think about, okay, you suffer from one chronic disease, but more and more are caused by people living longer, by the lifestyle, especially unhealthy lifestyles that become more and more of a problem. We see that people tend to have more than one chronic disease. So this multiple chronic conditions is an even harder problem, because then people not only have to learn how to live with one and how to manage one, but they have to learn to live with different chronic diseases, learn how they interact with each other, and it makes the whole story a lot more complicated. We now talked a lot about the personal aspect of it, but it's obviously also a financial burden. So we know that for healthcare insurances, and for the general healthcare social sector of countries, this is a very heavy burden that people start having chronic conditions and then have to live with it. So also there's this management aspect of it that obviously also plays a role, and we have to have it in the back of our mind. this is something that affects people on a personal level and affects the budgets of countries. I have it here in a bit of a smaller font, but it's also interesting to put it, to think about that even though there is this financial burden on the economic side of it, 99% of the actual management of a chronic disease is done in the hand of a patient. And when you think about it, you have, for example, an unhealthy lifestyle, you develop an NCD, now you have to start living with it. And then you have to do the whole job of learning how to deal with it. You have to be the one that gets up in the morning, does the exercises, take the medication, change your behavior, which probably in the first place taught you to have the NCD. So this whole burden on the person, besides this medical aspect of being sick, is very heavy and definitely should not be underestimated. And now that we know that it is a problem, we obviously want to think about what we can do with it. And since at ETH we have this very strong technology focus, we want to do something with technology to help people. And there are two big areas. I sort of gave it away already, but there are two big areas that we focus on with our research and also with the impact that we want to have. One is really the prevention part. So as I said, we know it's a financial burden, we know it's a personal burden on people when they suffer from a chronic disease. So if possible, we try to prevent them actually getting one. So we try to develop certain technologies, may this be chatbots or conversational agents, or may this be any other type of technological solution. I will briefly mention one later, that can help us that people change the behavior in the first place if they have some unhealthy behaviors, so they don't even get to the part where they have to suffer from a chronic disease. However, obviously we can't prevent everything, and there will always be people suffering from chronic diseases. And so the second part is, as I said it before, is the management of the diseases. So now that people started suffering from one, we want to support them, especially when we think about, okay, it costs a lot of money to do disease management for chronic diseases, and it also costs a lot of time. So very often healthcare professionals, so regular doctors, don't have the time to, on a daily basis, contact patients, on a daily basis, ask them how they do, whether they do their exercises, whether they take their pills, whatever. This whole management process, they can't really take over. Even if they could, it would be even more expensive. So there is always this tension between the time that a patient needs, the time that a doctor has, and the costs that are related to it. So what we do at the CDHI, so the Center for Digital Health Interventions, we very often work with chatbots or conversational agents because they are scalable, they are digital solutions, obviously, and they are cost efficient. So it doesn't make any difference whether we have one patient or whether we have 1,000 patients. They can all interact with the patients at the same level, with the same intensity, and more or less, obviously there's a bit more money involved if you have more people and you need to have more server capacity, but still it's less of a burden than having an additional doctor for every additional chronically diseased person. And so this brings me to the next part, the second part. Now we talked about the digital healthcare part, and we now know why non-communicable diseases is actually an interesting topic, and not only interesting but relevant. We now shift to the more technological part and talk about conversational agents in digital healthcare specifically. And when we talk about such conversational agents, this is actually a very broad term. It can be understood very broadly, it can be understood very narrowly. The definition that I like to use, and I also used it in one of my papers, is that when we think about conversational agents, we really talk about any sort of computer system, may this be rule-based or may this be intelligent, that imitates a natural conversation. So obviously we can have different levels here. We can have very stupid conversational agents that mimic conversations very poorly. So where it becomes very obvious that it's only a system, and where we have very limited capabilities. But we can also go to the other extreme, where we say we have conversational agents or systems that act very intelligently and can really bring to life this feeling of being in a conversation with a counterpart. This is actually the second part of the definition, where we say they imitate a natural conversation with a human. So we always have this human-computer interaction part, where we say we have the conversational agent stupid or not stupid, intelligent or not intelligent, interacting with a human patient in our case. And this can be done via different formats. So this is the third part of this definition. We look at images that conversational agents can use to interact with patients. This, for example, a very obvious example in this case is taking pictures, for example, of the pills that a patient has taken, or taking pictures of skin, for example, when it's a skin-related disease. Obviously, we can use written language. We can also use spoken language. Maybe to already give that away a bit, very often we use written language, so text-based chatbots, simply for the case that they are easier to regulate, in the sense of it's easier to guide the conversation and to know what the patient is capable of or is allowed to answer, what the chatbot is capable of answering. This very often has to be the case because otherwise it would not be, it could not easily be compared with each other if you have different conditions. And B, since we work with real patients and it's a healthcare related environment, we can't just go wild and open up everything and let the chatbot tell the patient anything we can't regulate. So there need to be certain boundaries. Also, I studied, we very often use text-based chatbots, but now we move more into the field of also voice-based chatbots. So being able to interact with patients via voice. We all know by now voice-based interactions with Siri, for example, or with Alexa. I mean, I don't need to go into more depth here. But again, in healthcare, it's a bit more complicated since we can't be that open. However, we know that people get more used to it. So obviously, we also want to use that in our research. So further down the line, we can have voice-based chatbots also when it comes to the interaction with real patients.
Theresa, sorry to interrupt you again. Did you say you used voice-based agents in your research as well? Or is it just the trend you're talking about?
A, it's a trend, and B, within our center, we already started using them. I personally haven't worked with voice-based agents, but there's more and more a trend towards that also in our center. Yeah.
Still thinking about it's communicable. Yeah, you said NCT. Let's say like this. It's easy for me. So the NCT problem, right? So it's people can't talk about it really.
Oh no! It's not that I can't talk about it. It's that you can't get it from somebody else. You can't get cancer from another person.
So that's got it. Okay.
Yeah. It's basically it's diseases that are not contagious. You can't get COPD or asthma from another person. Yeah. But still, I mean, from a semantic perspective, yes.
Okay.
It would be an interesting aspect.
Just coming back to the voice thing, we had some controversy in the past when thinking about what Google once did at the I/O conference, using a voice agent to order a pizza. You probably how is the discussion at the moment using voice in a healthcare context or in any context with humans? What's your experience with it? Do you have experience, or did you test it in some ways?
So as I said, I personally haven't worked with voice-based agents, not in a research project setting, but I co-authored a systematic literature review where we really looked at what is the current field of voice-based agents in healthcare. So this definitely is a topic, and as I said before, there is projects going on about voice-based conversational agents in healthcare within our lab. What we saw in this very, very extensive and very broad literature overview, which is super interesting because it really shows you what the current state of the field is that it's at a super nascent stage. So very early, there is not many structures, not many standardized ways of measuring the quality or the setup of such a voice-based agent. So it's all at a very, very early stage when we think about it from a research perspective. This, by the way, is the same for AI-based chatbots. So also when we even talk, and voice-based is even further evolved than when we say regular AI-based chatbots, because I mean, AI technology has been around for quite a while. I mean, I don't need to tell you that, but it's been around for quite some time, especially in business applications. But when we look at it from a purely research perspective, and this I think has to be done to some extent also when we think about the managerial implications, especially when we think about healthcare chatbots. We don't want to have any systems out there that have not been systematically and in an organized way being investigated and tested, whether they really work, what are their effects, what are their shortcomings maybe, what is still open to discuss. This is what we do in research. So especially when we think about applications of AI-based healthcare chatbots, it might be worth a look going to research. And when we look then at the research papers that are out there about AI-based chatbots in healthcare, we see that there is actually very little. So you come to a very, very small number of papers that specifically work with AI-based chatbots in healthcare. So it's about 10 or 11 papers. So this is shocking. I mean, normally you would expect, okay, there's like 200-300 papers that really look at AI-based chatbot in healthcare, because it's such an obvious topic. I mean, healthcare, as I said in the beginning, is at the heart of everything. We all need our health. AI is in everybody's mouth. I mean, it's a buzzword for, it's not for no reason that it's a buzzword for a couple of years now. But nevertheless, then having chatbots interacting with real patients, running on AI software, and having been systematically and objectively been tested by research is basically non-existing. So it's at a very early stage and just evolving. Little regulations in the sense of there's no real structures of whether you can use for comparing different chatbots against each other. There's no it's just basically Wild West to some extent, if I want to over exaggerate it. And so why you mentioned that is sort of coming back to your question about voice-based. Voice-based is even newer. So not even with the AI-based chatbots, we have to have solid basis that we can say, this is what works, this is how we evaluate it, this is how we compare them against each other. Voice-based is at an even more nascent stage, even younger and even less researched. Nevertheless, we started doing it. So you can't wait for the others to do it. So you have to run your own research projects. But yeah, as I said, I personally haven't been involved in the practical applications of it.
Jasper has asked questions in the Q&A section, I think, which is also good fit in that context. Maybe answered later, but you tell us. He's asking, what are the scenarios in which these conversational agents are used? How do we co-perform with healthcare professionals?
Perfect question. Thanks for that. So you're really leading my presentation via the questions. That's perfect. I will talk about it later, but I can also motivate what I will say later already now. It's really an excellent question, because we need to think about this coexistence, and we need to think about how these two players, healthcare professionals and chatbots, can work with each other. Taking one step back, when you say different scenarios, there's obviously, I would say, three main scenarios when we think about these two actors. One being we only have healthcare professionals, no digital solutions and no conversational agents, the traditional view. The other extreme, we only have conversational agents or digital solutions, no humans involved anymore. One might say this is the future scenario. I don't believe in it, because what we believe in and what we do and what we also very strongly support and foster is the middle scenario, where we say both the human as well as the digital solution have their right to exist, have their benefits, have their shortcomings, and we need to combine them. We need to have a unified approach for preventing and managing chronic diseases in a way that, and I think this is very logically, and everybody would agree to that, or makes sense to think about it like that. When it comes to complicated emotional scenarios, such as informing people about a disease, so sort of communicating the diagnosis, this is a very emotional setting where not even one human has the right solution to communicate that to every human. So there's a lot of personal differences, what type of healthcare professional clicks with what type of patient. This was also part of my research for some time now. even there we see differences, that not every person can interact with every patient. So we even need to dare to have certain types of doctors being able to interact with certain types of patients to really have this emotional connection. On the other hand, there are aspects where the time and the expertise and the related costs are not best used when using humans. And I already said it before, especially when it's about repetitive, easy tasks that lots of people have to do, maybe at different times, but repetitively and more or less always doing the same. This is very hardly thinkable that this is done by especially a trained professional healthcare professional. Yeah. So for this, it's very good using digital solutions, because they don't care. They don't care whether they interact with one patient or with 1,000 patients. They are scalable, they're digital, they don't have emotions in that sense. Even though more and more we become to be able to imitate this person connection. And so this is something that I researched for some time now, saying that we have this interaction between different humans and sort of different doctors and different patients. So not every doctor can interact with every patient, but it is very, very important to have a connection between the two. So there needs to be this person connection. Why? Because if you like a person, if you click with a person, you're more likely to bond with that person. You're more likely to accept the diagnosis that you get. You're more likely to follow the treatment that you get advised to follow. And last but not least, what is the goal of following a treatment? Having positive treatment outcome. So it is important to think about this doctor-patient relationship. There has been a lot of research going on about that. This is a very validated and proven aspect of medicine. We know that we need to think about what relationship takes place between the doctor and the patient. So far, this has been not the case when it comes to conversational agents. So far we had one type of conversational agent. It might click with a patient, it might not click with a patient. We didn't really think about it. We might have different versions, but always applying the same to all patients then. And this is something what I did. I transferred these relationship types from human to human interaction, so human doctor to human patient, to conversational agent patient interaction. So saying that depending on what type of patient we have on the other end of the conversational agent can have one type of interaction style, one type of relationship style, or another type of relationship style. This now goes a bit further, but to sort of give you a short example, there are some people that like to be told what to do, in the sense of they don't know how to deal with their disease. They might be insecure. They might not want to think about it too much. They don't like to discuss much. They just want somebody to tell them, okay, today's Monday. You need to take pill A, B, and C, and you need to go out for a 5-kilometer walk. Just do it. Other people might not be very happy with this approach. It's very paternalistic and very authoritative approach. They like to have somebody who tells them, hey, I know it's been a rough week. I know that the weather is bad outside. I know that you don't like it when it's raining. What about you take it a bit easier today? And by the way, you need to take your pills. But why don't you, instead of going out for 5 kilometers, just go out for 3 kilometers? Sort of being more in this deliberative shared decision-making process type. So far, we only had either the one type of conversational agent or the other type of conversational agent. And now with this approach that I co-developed with a colleague of mine, we can say, depending on who the other person is, and we don't need to have much information about the person, we can adapt the style of the conversational agent. We can really make them be either the authoritative paternalistic type of conversational agent or the deliberative shared decision-making type of conversational agent. And so we can see already with this very short and easy example that yes, there is certain aspects that we know, again, circling back to the question of the audience, we know that there are certain aspects that are super relevant that the healthcare professional take over when it's really about the hardcore emotional parts, for example, or the really complicated diagnosis parts. There are parts that take the conversational agent. And there's also some aspects that we can learn from the human and implement in the conversational agent and make the conversation between the conversational agent and the patient even more pleasant and even more efficient and effective. Because in the end, why do we do that? We want people to either change the behavior so that we can prevent the chronic diseases, or we want them, once they have it, learn how to manage them. And for that, obviously, we need to have this well-working relationship where the patient follows the advice, agrees with the conversational agent, creates a bond with it, and last but not least, then have a positive treatment outcome. So long answer to short question. I will even talk more about it with the example.
No, it's perfect. Examples are always great.
Sorry, what did you say?
Examples are always fantastic, so everything's fine.
Perfect, perfect. But let me now continue and give you a brief overview before we go to the examples about the sort of more technological setup of what we use in the CDHI when we develop conversational agents. And so there's one important aspect that we continuously use in our projects, both the research aspect, but also when it comes to, okay, we want to be a bit more applied. This is Mobile Coach. And Mobile Coach is an open source platform that we're in-house developed, so to say, by the members of the CDHI. And this is a very powerful platform for really setting up complex health intervention logics. It works for mobile, works for Androids and for iOS as operating systems, which is important because very often you only have one or the other, and we need to have both when we really want to reach all different types of society levels. What we can do with it, and this is worth taking some time and discussing in a bit more depth, is when we talk about health intervention logic, this is something that might look simple at first because you say, oh, well, it's rule-based. You just set up some logics and then the intervention runs. But it's actually a super complex process where you really have to define not only, again, which looks simple, when is the chatbot interacting with the patient, what are they talking about, but also all different sorts of scenarios. What happens when they postpone? What happens if they don't want to talk? What happens if they don't come back? How do we get them back? At what time do we reach out to them? What happens if their screen is locked? Do we reach out to them or not? What happens if they have to give us access to, I don't know, their camera or the microphone? How do we motivate that? How do we bring them out of this digital interaction? Can we have any sort of intervention logic that makes people put the phone aside and do something and then come back to us? Is there anything that we can do for them to start interacting even with other people around them, sort of include them in the process of, for example, managing the disease or learning how to prevent getting a certain disease? So this can be very, very strict and very, very rigid with little room to move for the patient. But as we know, life is not always predictable. Life is not always a pure rule-based approach where we say, we know that exactly every day at 8 a.m. we look at the phone, then we get a message and this is how it works. Yeah, you're nodding no. This is what's not really happening in real life. So with this platform, what we can do is we can implement certain reminder mechanisms and certain dynamics where even though it is a conversation that is fixed and rule-based, and a conversation that is the same for all the patients that we have, because it's still research, so we need to be able to compare different people to each other and different data outcomes to each other. We can still have certain flexibility and allow people that they might postpone if today is a really bad day, or today they have a lot of work to do and they can't really follow the intervention session that they were supposed to do. And by intervention session, it means that they, for example, either have to fill out a survey or have to do an exercise or have to do, I don't know, a certain walking exercise or some physical exercise or whatever. So we can build in some flexibility that makes it look for the patient, or for any human interacting with it, as if it's a real conversation and really personalized. And this is something that obviously needs a lot of sort of thinking in the background and also structure to be able to keep it under control and also keep the data comparable to each other. I said it works for iOS and for Android. Not only can we program apps with it, we can also have a browser-based web cockpit. This is also important when we think about it, and it sort of again comes back to the question of what do we do with other stakeholders? What do we do when it comes to having healthcare professionals or other stakeholders being part of the conversation? this is quite a neat tool that we can use for healthcare professionals, having an overview of all their patients when we have a setup. And I'm triggering sort of the example that we'll give later, because there is multi-stakeholder environments where we not only have patients, but also healthcare professionals being part of the conversation. And they obviously want to know what their patients are doing, and they want to know how they're performing, whether they have any questions or something, whether they're following the advice, whether they're following the intervention schedule. This is everything, and this is something we can all organize in this web cockpit. I said it, very often we use rule-based interventions, but again, it's not as easy as it sounds, and it doesn't in no means take away the fun out of it, and it's in no means less important and old-fashioned. It's necessary in terms of research comparability, but also since it works, there's no need to always go beyond what is possible to do. So there's no need to over-engineer and just for the sake, because we can do it, push some AI on it. I think it's always important to know where do we need it to use it, and where it's also enough to use traditional setups. And in this case, very often we use rule-based interventions and chat-based coaching. But don't worry, there's always some AI also being part of it. So I'm not going to disappoint the listeners here, I hope. I already said it, with that we are capable of being fully customizable and really having interventions that are per se comparable to each other, but can be adapted to different patient populations. I said it at the very beginning, we can work with people with respiratory diseases like asthma, but we can also work with people suffering from obesity or diabetes, or use that for example, working in the prevention part when it's, for example, about stress management. Last but not least, we do include some AI. Otherwise it would not be fun, right? So we have some specific algorithms for specific applications that we can then include in this rule-based logic, and here have the possibility to further develop what is possible to do and gather some interesting data, but also have a bit more flexibility, of course, when it comes to the interaction with participants. I will come back to that in my second example of a research project, but just to give you an example what type of algorithms we use there, or we can use in our settings. This is, for example, when it's about cough detection. So being able to say, people are coughing at night, when they have asthma, this can mean something. And obviously it's different for every person, and it's not about telling them what to do when, but really being able to detect, people are coughing, and this is a certain cough that gives me an indication that an asthma attack might be around the corner. This is something, a very applied example of what we can do. Another one, and I will come back to that later, is about breathing training, but I will not talk about it now. So that is
pretty interesting. I think it's also fine if you say it doesn't need to be AI based in all cases.
Yeah.
As I said, rule-based interventions are pretty good, or probably just necessary in a research context. Just to control the situation and the groups and the testing. I think that's a good hint. Just think about it, not only, we always have a discussion, is it AI or not? So, but there needs to be kind of learning where we say we need to control situations, and AI-based it's not possible to control, because there can be any kind of feedback to a question. And this was helpful for me to understand. Integration of feedback, biofeedback algorithms is also interesting. So from just leaving the path of having only text chat, as only, sorry about the only, right? Having text chat, having that kind of sensoric, which helps us to understand what's happening on the other side, which goes beyond text as response. So just observing is also kind of, it sounds like surveillance. Don't think about surveillance for a second, but observing the environment of the person you're talking to as a machine, and understand what else can we do in the conversation. That's pretty interesting.
Yeah, I agree. I'm glad you picked it up and that you highlighted again, because it shows us that we can have this seemingly simple type of intervention, typing, even though it is still very complex and it's not very easily done. But at the same time, we can also have very complex interactions that go beyond what we can do as humans. So for example, I would not be able to detect whether somebody is having an asthma attack a day later, just depending on how they cough. I would simply not be able as a human to do that.
Yeah.
Same goes for breathing feedback. By no means I would not even be able to observe my own breathing in real time, saying, oh, now I have exactly X amount of milliseconds between breathing in and breathing out. I mean, maybe if I really focus, but I couldn't do that for other people, or I wouldn't like to do it, and it would take a lot of effort and time, and it's not necessary. But if you use it with an algorithm, or if you use an algorithm for that and implement it into this seemingly easy conversation, we can have a lot of benefits, and we can have a lot of real-time interaction that again makes it very personalized and very very close to the patient at hand, even though the rest might be rule-based and predefined.
Sorry, because I think the conversation is getting quite interesting. I get so many questions from the audience as well. Dirk, I will answer. I will ask the question a little bit later. It's not forgotten, so don't worry. But just wise, immediate questions in that context of what you have been talking about now. And he writes, for example, about an asthmatic coughing triggered me. My wife, for example, is hesitant to use the app Sleep Cycle to detect her coughing because it records all her data. Following up from my last questions, I will ask a question later on, but following up on the question he had about design and deployment. How do you design for trust between people with NCTs and these systems health institutes?
Yeah, very good question. Yeah, trust is indeed something we need. It's super important for us, as it seems to be obvious for the participants here, for patients to trust the conversational agent. And it's definitely something we not only measure, but we try to initiate from the very beginning on. And one way of doing that, for example, is, and this is a very specific type of behavioral item we can use in our context, is if the agent gets introduced by a healthcare professional. So again, coming back to what we discussed before, healthcare professionals are a super important part of the conversation. They belong to this environment. They need to be on board. It's not about getting rid of them, but it's about onboarding them and working together with them. Very simply, because in this context, if a doctor tells a person, this has been developed for people like you, this works, I trust it, I recommend you to use it, I also have the ability to oversee it, I'm still there for you. There's also a dedicated chat channel in the app within the app that you start working with. You can also reach out to me. This goes a long way, and this really makes the whole story a lot more plausible and a lot more trustable. People just know they are A, not alone, and B, they're still a human, at least via one chat channel. There's still a human there that they can interact with. What we also do in basically all our projects, we ask people how close they feel to the chatbots. We asked them whether they can set up a certain bond with the chatbot. And this gives us an indication how much they trust the chatbot and how much they trust this whole setup. Obviously, we now know that there are certain things that we can do for them to trust it more. And there are things that you probably should not do. And these are things, sometimes very small things, like whether they have an icon or not, how do they address the person, do they use a name, can I use the type of chatbot that I interact with. So these are all aspects that we can take into account when we then design the chatbot. So there's two parts. One, this really design part, how does it look like? What can it do, what can it not do? What does it say about itself? Does it say, hey, I'm the all-known chatbot and I'm real? Or does it say, look, I'm a chatbot, I'm still in the making. There are things that I can know, there are things that I don't know. Let's start the conversation together. This, for example, is a much better way. And secondly, as I said before, there is this aspect of a trusted person introducing the chatbot. Actually, what is interesting and what people might not or what people might not know, but what we know from the 60s already, so quite a time when there were no such elaborate conversational agents like we know them today. Even then, there were experiments going on looking at, do people start trusting such systems, and can they build relationships? And very interestingly, even at that time, when it was obvious that it's a line of code and that you don't talk to a person, people started assigning personalities to software. They started assigning relationships, and they said that they start trusting the code. And this is something that is known as the computers are social actors paradigm. So we know that obviously if you do it really badly, then they're not. But if you follow certain setups and you create the feeling of interacting with software, people start without much problems having a relationship and trusting that software. This is super interesting. This is something that we should never forget, because it's also very powerful, and we need to be careful, because this is again coming to the question of, we can't just put out any free text speaking type of chatbot when it comes to personal and important matters of personal life for people, because people trust that software and they have a relationship to it, and they get disappointed. And they don't want to disappoint the software. They don't want to disappoint the chatbot. They don't want the chatbot to think that, oh, I didn't do my exercises. It might sound a bit far-fetched, but it has been proven over and over again that this happens. And so again, thinking about, we interact with real patients, we interact in a really important sector, we need to take this into account as well when we set up our chatbots. With that, I think it's a good time to go to the next part, which is really
maybe just one, because I know what kind of slides are coming, and I think Dirk's one. If you could just go back for 1 second, since you have been talking about conversation, and Dirk had a good question regarding reliability aspects in the context. I think it might make sense to ask it here. He is actually asking, can you say something about reliability aspect? For example, if a conversational agent gives advice that at the end of the day turns out to have caused harm to the patient, does that kind of CA, conversational agents, do give advice, or is it just not the purpose?
It depends, of course. So there's a lot of apps out there, commercial apps that give advice. I mean, they are quite famous ones like the Woolbird from Stanford. Very often, or not very often, sometimes they run experiments to find out what happens and to sort of overlook their own chatbots. Very often there are no experiments, and chatbots are just out there and interacting, also on sensible topics like mental health. It is critical. So very often when you look at the small print, das Kleingedruckte am Anfang, they just say we don't take any liability. I think this is a very critical aspect, because as I just said, people start trusting the chatbot, and you need to take that into consideration, and you need to, at least to some extent, take responsibility for what you do. We personally, with our projects, engage in, I would say, circumcised environments, in the sense of that sometimes we give advice for people to do, but very often we only ask for very simple things to do. So such as, okay, you take a couple of steps, so some walking exercises, or breathing as well. I will give an example later. I mean, it would be very hard for people to die from that, or to have serious harm from it. However, obviously, if we have longer interventions where people have to do certain exercises where there could be any problems, then obviously, we need to think about liability issues and being reliable for what we do. Again, here comes this interaction with the healthcare professionals quite handy, because we know, okay, they can interact with a doctor, and there can be this fallback option of a real person looking at data and looking at how people perform, for example. So I can give you a very concrete example we have, and I will go into more depth and present the project later in a second then. An asthma chatbot for children. And so this is obviously a very sensible population. It's children, so they're between 10 to 15 years old. And they interact with a chatbot, and it goes for a couple of weeks, and they have to do things in real life. And they, for example, have to show their their inhaling procedure. So there can be quite a lot of mistakes that they make, and something can go wrong. But what we do is we don't let the chatbot decide whether it's right or wrong what to do, and we don't let the decision be on the shoulders of the chatbot. But we forward such conversations and such decisions to a real person, but not randomly, but again, by a very dedicated approach, very dedicated channel with very dedicated things that the healthcare professional has to do. So they only need to spend 3 to 5 minutes. They get informed, they don't have to act on their behalf, but they get informed, or a patient just submitted a video about their inhaling procedure. Please look at ABC. And they start looking at it, they make the decision, they decide whether there was a mistake. They give feedback to the patient, and they even interact again with the patient when there was a problem. So the chatbot really works as an orchestrator and is able to decide, obviously, I mean, it was predefined, but it looks for the patient as if the chatbot is deciding, this is something I take over, and this is something that a human looks at. And again, when I think about a lot of commercial applications that are out there and that have not been checked or do not have this option, I personally might have some ethical situations with it, or maybe problems with it. I like the way that we do it, and I think it's a very sensible approach, and also a very good approach for the patients to not only have trust, but also be able to know that when something happens, there's a real person I can talk to. Thank you. Perfect. So also looking at the time a bit, I think it's a good time to go to the examples. I mentioned a lot of examples already now in the course of these slides, but I still want to take the time to pick 2 projects, and one for prevention, one for management, and show you a bit more what we do and what is that we look at and what is that we can find out with such research. And so as the center per se is focusing on specific entities, I want to present one on management, one on prevention. I start with management because this is the project that, it's one project that's already finished. The other one is still new. So for this, I want to present a chatbot that actually does exactly what we now mentioned earlier a couple of times, orchestrating multiple stakeholders, orchestrating patients, orchestrating family members of the patient, and orchestrating healthcare professionals. So in a bit more text, this is what I just said. So it was a very lengthy text, so to get a lot of information into one sentence. This is a chatbot that focuses very specifically on asthma in children between 10 to 15 years old. And here I mentioned very often the interaction between healthcare professionals and patients, but there's also another stakeholder group that we should not forget about. And this is family members, especially when it comes to children, but also when it comes to any person of any age. We are not alone. We have friends, we have family. They also know what's happening to us. They are also, to some extent, affected by our disease, especially parents of young children. Very often they have to take care of the disease management. But also when we think about people that suffer very heavily from their diseases, cancer, for example, or COPD at a later stage, obviously this affects the surrounding. And we should take that into consideration. We should also make them part of the conversation. And this is what this chatbot is doing. It connects young children with healthcare professionals and with family members. The project per se was motivated by the question of whether this would actually be possible, in the sense of whether people would adopt it. So here the trust comes again. So you see, this is a very important topic in our research, and we really take it to our hearts because it is important that they all trust each other. The healthcare professional needs to trust the chatbot, and the chatbot needs to trust that everything works well. And the family member needs to trust that the chatbot is doing the right thing and not harming the child of the family. Obviously, the family members also need to trust that the healthcare professional reacts in time and does his or her job. So we see there's a lot of trust in this whole setup involved, and we need to see, can chatbots generate such a trustful interaction between children, family members, and healthcare professionals. Also, I said at the beginning, there's a lot of design aspects obviously involved for motivating trusted designs and or trusted chatbots and trusted interactions. And so we were interested in, from a design perspective, and design really understood in a broad sense, from the intervention logic, from the look and feel, from the type of wording that they use, from the, whether it's rule-based or not, how do we have to design this whole chatbot and intervention if we want to have this trusted interaction. There was also a second level goal under the assumption that, yes, we are able to do that and we are capable of setting up this trusted interaction. We were also wondering whether this could have a positive impact on asthma management in children. Obviously, because it's nice, yes, to have a trusted stakeholder orchestrator, but there's always a reason why we do that. We don't do that just for the sake of it because it's nice to know, but we want to have a positive impact on affected people. We want to help them to manage their disease better. Very specifically, disease management in asthma in children in this case means two things. One, improving children's cognitive skills, and two, or B, I don't know whether it started with A or with one, let's say A is this and B then B is the behavioral skills. So we want to know whether children actually change their behavior and, for example, know how to better use the inhalator, or know what to do when they have an asthma attack. So everything around managing the disease that they have. And so to show you how this is set up, and the design is here in a very childish way, I would say, but it was for children. So you can really see the chatbot's face, or the avatar. Children could choose between a female and a male avatar. That's the female version of it, Max or Maxime. And you can see the chatbot is really at the center of the conversation. The chatbot connects with all different stakeholders on different channels, but they are all also connected without the chatbot. So we can see that the chatbot is interacting with the doctor or the healthcare or the asthma expert in this case via email, but there's also this web-based cockpit that I mentioned before. We can see that Max is interacting with the patient via a dedicated mobile app. So this happens in a chat where they just text with each other. It just looks like on WhatsApp, but very specifically designed for children. The whole design is look and feel of one coherent app that is child-like and that is suitable for that age. We also have the family members interacting with the conversational agents. This is done via SMS, and this is used for example, reminding them when the child is not continuing with the intervention, or when there is some specific question. We obviously have the family member interacting with the patient face-to-face. And this is a very interesting aspect, and we put it into this graphic, or into this little picture, because it's not happening anyways. I mean, obviously they interact with each other face-to-face, but it's something that is triggered by the conversational agent. What we mean with that is we bring children out of the digital world and out of the digital interaction, bring them to real life. And the chatbot in this case, for example, tells the young patient, child, hey, there's an interesting experiment. This can help your family members to better understand your disease. Because again, as I said in the very beginning, disease management is very often in the hands of the patient, and especially with young children, this is very often in the hands of the family members. And so the child gets an exercise, part of the intervention logic, to go out, get a straw, give it to his or her mother or father, and ask them, put the straw in your mouth and walk up the stairs and try to breathe through the straw. This is how I feel when I have an asthma attack. And so this is something where we try to make everybody part of the conversation, and let patients, family members learn something, but also let the patient learn to talk about their condition, to involve others, to sort of interact with the disease and learn, hopefully, to manage it. As you can see, this is quite a I would say complicated setup, especially when you have to plan everything up front. So I hope this gives an example that rule-based doesn't necessarily mean boring, but can have a lot of complexities in itself, and can also create this image of having a real interaction and real connection with patients. To maybe solve the puzzle of these two questions, yes, we were able to develop a trusted collaboration. We were able to, when we asked patients and family members to create a bond and a connection with the chatbot. They really liked it. They gave very positive feedback. Also healthcare professionals. So they also reported very positively, which is important because they have to be part of the conversation. They have to like it, and they also have to promote it, as I said at an earlier time. Also for the second part, we could see that such conversational agents can have a positive impact on cognitive skills, measured as literacy, so knowledge that children have about their disease, and also on behavioral skills, measured as, for example, how well they can conduct their inhalations. So that was a very positive research project, and yeah, a lot of happy patients and happy family members and healthcare professionals. So again, very motivating to conduct such research. Now coming to the second example, this is conversational agents for the prevention of chronic diseases. So basically one step before. This is a project that I just started, and this is where I was exchanged with MIT about. This is two conversational agents that target vulnerable populations, especially when it comes to the prevention of any sort of disease. And we do that via stress management. So we know that stress is a predicator of a lot of different chronic conditions, and we want to avoid people going into chronic stress situations so that the likelihood that they develop certain chronic diseases decreases. We do that in a rather radical way for research because normally it's all very traditional, and you have the healthcare conversational agent sort of with the view of you have to do this, you have to do that, or collaborating, but still being very obvious coming from a healthcare perspective. And we say, if we want to motivate people from vulnerable populations, so with a lower socioeconomic status, to care about their health and to do something about chronic diseases and to become less stressed, it's probably not the most or not the best situation or the best solution to give them the super well educated bossy chatbot that tells them what to do, not to do. We would rather get them via social influencers or even via gaming. I mean, lots of people game, they are in front of the computer anyway, so why not sneak in some healthcare management and some stress management? Hopefully they like it more and they get more motivated. And what we do is, and I can already go to the motivators and to the questions that we have here. We want to have different, and we develop conversational agents with different interaction styles, what I mentioned before, something that we are now able to do. And they should either come across as a social influencer with a healthcare topic still, but really much closer to how people interact nowadays, especially if you don't have chronic diseases. Why would they download an app about chronic diseases? But a social influencer styled conversational agent that motivates them to do some stress management exercises. Or even more interesting and exciting, I think, is we create a little game. It's actually in the style of The Witcher 3. It's a very popular game where we are allowed to use the characters and to create a little quest where gamers are just motivated to interact with a chatbot, but it's not even about healthcare. So they don't even know that this is very specifically about stress management, but they're motivated to go on a quest and to look for a person, and for that they need to go on a boat and make the boat sail. And this is actually the exercise then, where we include the slow-paced breathing exercise, where we have this algorithm that I mentioned at a previous slide that is capable of understanding breathing patterns and breathing in and breathing out, and gives real-time feedback to the participants whether they breathe in long enough and breathe out long enough. So basically they train breathing patterns, breathing pattern being the exercise for reducing stress, because we know that when we have a slower paced breathing, we can reduce stress. They engage in this exercise without even knowing that it is for stress management. And so the hope with this is to see that they interact with such a chatbot, and then that they interact longer than when it's a really healthcare dedicated chatbot. So basically showing that when you do a very low level interaction and a very low level healthcare related interaction, people do it and they learn how to, in this case, manage their stress without having to actively look for it and to actively be motivated to do something about their health. And so overall, to basically sum this research project up, and I think it's super exciting because it's something that nobody has done before, and it's a very novel way of trying to motivate people without even knowing that they do it, not in a malicious way, but really in something that is close to their regular life and close to their regular behavior, and so they don't have to go this extra effort of becoming interested in health. And so we're interested to see how well we can reach them, whether such a chatbot motivates them enough, and whether such a chatbot can be used to, at a very easily approachable level, support this prevention of chronic diseases. To give you a feeling of how this looks like, I talked about a boat now that people have to move. This is a screenshot of how this looks like. So again, you see it's really a game style view that we have here. It doesn't really look like anything healthcare related. It could be part of any type of game. And people just have to put their phone in front of their face and breathe in, and then the boat moves, and they have to breathe out, and it moves slower. And this all happens in real time. And they just have the goal of moving the boat from A to B. So, for example, in the context of the Witcher game, they have to sail to an island to go on the next quest. So it's something they would do anyways when they're playing a game. So they anyways would move their characters around. But here they just have to breathe a bit. Okay, doesn't really look like healthcare intervention, but in reality they learn how to do such slow-paced breathing. And so this is, in my view, super exciting. We're just at the beginning of it. So we don't know whether we actually reach the people that we want to reach, and whether we can motivate them to stick to such an exercise. And we don't know whether they stick long enough to learn something from it. But let's see. I think it's super exciting, very close to the populations that we want to influence, and hopefully a project with lots of impact. With that, I'm already at the end. And if there are any more questions,
yeah, sure.
Very happy to answer them.
Thanks very much, Theresa, for the quite awesome presentation. Could just go back one slide. It has been just fascinating for me because when I was listening, I heard so many hints on how you actually design things, right? Mm-hmm. Design a conversation agent. And looking at the questions from Gaspar, I would like to allow you to speak up yourself. I just put your audio so that you can talk if you like. So here's more questions on regarding the design with the process itself. Mm-hmm. Gaspar.
Yeah, I'm here.
Thank you. What are your questions?
Yeah, so first of all, amazing presentation. I'm really, I think it's a really great approach also to take game design to reach vulnerable populations and to engage people in a non-paternalistic way. Mm-hmm. I was wondering if you also consider in your design different cultures, ethnicities, as these also intersect with more vulnerable populations and demographics.
Yeah. Very good question. As I said, this is just at the very beginning. So far, we don't look at the very detailed differences. What we do, however, is at least to make a difference in the language for approaching people. So we have one set of participants that get reached out in English. So we focus in the UK and on Ireland. And we have one set of participants that get approached in German. So this is for the DACH regions, Germany, Austria, and Switzerland. So far, this is the main differences that we make in terms of reach out. We obviously ask them about certain aspects to define their socioeconomic status, which is mainly about education and background. We don't necessarily ask right now anything about their ethnicities, but Again, and coming back to one of the projects that I briefly mentioned before, we know that, and I think this is definitely a gap in research. We know that very often such chatbots get only tested with very homogenic cultures. So Western societies is normally 90% of the population, or even 95, or even 100% of the populations. So it's very rare that such a project gets tested in, I don't know, any African country, for example, or in a variety of Asian countries. I think this is a lack, and I think this is something we should definitely focus more on. We don't do it right now, but it's planned, since there's this second sort of, I don't want to say hub, but it's ETH has set up it is a research hub, we can say that, in Singapore. The plan is also to run this experiment with a population in Singapore. And obviously, especially when it comes to gaming, this could yield very interesting insights. So I personally would be interested to see whether we can reach at an even faster time and with more success, more people in an Asian environment, simply because gaming per se is much more progress there and much more part of the DNA of everyday's leisure activities than it is here. So this would be one very cool differentiation that we can make, or one very cool insight that we could have. We don't do it right now because we first want to set it up here in the UK, Ireland, and the DACH region to see whether per se it works, per se we can reach enough people to gather some data to further improve the algorithm. But it's actually planned to be done very soon in Singapore as well.
Yeah, great. Thanks for answering the question. Indeed, your research field is also very nascent, so I appreciate that you're actually taking these things into account. It's great.
Yeah. Thanks for saying that. Yeah, it's, as you say, it's super early. For example, for this one, we use Twitch as an outreach channel. Again, I think it's one of the, I don't know, I haven't seen any other papers where they use Twitch to reach out to participants. But we said, look, I mean, this is where young people are. This is where probably vulnerable populations are. So we can't just go over Facebook, or we can't just go over any traditional reach out mechanisms. We need to go where they are. And we need to engage with Twitch influencers and Twitch gamers. And they're gonna be the ones that introduce the study and the little game, because it's only a short game, obviously, to their audiences. And we hope that this again brings us even closer to the population that we look at and that we want to support and that we want to have an impact on. And so yeah, there's a lot of new and nascent and moving targets, but I think it's just exciting, and it's important to be done.
Can I ask another question?
Yeah, I think the one with languages was also quite interesting. Yeah, go ahead, please.
I was wondering, in your research group, how much do you involve designers? What does your research group kind of look like in terms of where are you and what kind of people do you work with?
Yeah. So again, it always depends a bit on the size of the project and on the planned reach of the project. But very often, especially when we have longer time interventions, or we have really radical and rebellious interventions like this one, I would say it's a bit rebellious and radical compared to what other interventions look like. We do involve professional designers. So there's some aspects we can do ourselves, but we know about the importance of designers, and we know about the importance of storytelling. So storytelling is a very, it's at the very core of what we do. We need to tell the story of the conversational agent to the patients, may this be young patients or older patients. And here, I mean, we need to really create the story and the game. So sometimes you work with professional story writers, where we write complete storybooks for weeks of intervention. For this one, for example, we use professional designers to set up the avatars and to set up the characters of the chatbots that interact with patients. So it's actually a very diverse group of people that we have for such projects. And we have obviously software designers, we have people with a more intervention logic or support, that we call it support section, but it's not support in the sense of the support yadas, but they are more in the intervention logic setup. We have designers, we have storytellers, as I said. So very, very diverse group of people.
Great, thank you.
Thank you, Caspar, just for all the questions. That was awesome. Looking a little bit at the time again, I think, Theresa, I just want to say thank you, really thank you. It was awesome, your presentation. I liked it very much. It was very in-depth. You're a very knowledgeable person. It was obvious from just listening to you. Thanks again, everyone who just has been part of the journey this evening. And I wish you all a nice evening and see you again next time. So I say goodbye and thanks for listening.
Thank you very much.